I'm Jenny Myers. I'm a consultant obstetrician at St Mary's Hospital in Manchester and Professor of Obstetrics and Maternal Medicine. I'm delighted to be Joint Chief Investigator of the PANDA trial, and I'm going to talk through some of the background and rationale for the study now. So we all know that hypertension is the most common medical complication of pregnancy, with around 1 in 10 women developing high blood pressure during pregnancy. Many of those women will require antihypertensive treatment. The 2 recommended antihypertensive agents commonly used in the UK at the moment include labetalol and nifedipine. Labetalol is recommended as first line in the NICE guidance only because of its licensed status compared to nifedipine, but we know that nifedipine is also very commonly used in the UK to treat hypertension in pregnancy. We know that when clinicians and patients are deciding which drug to take to treat hypertension in pregnancy, that the decision at the moment is largely arbitrary and often based on clinician preference. The number of women recruited to trials that have actually directly compared the efficacy of labetalol versus nifedipine amounts to only 350 women. Clearly not enough evidence for us to really guide management properly. Beta blockers and calcium channel blockers are likely to be more effective than methyl-dopa in avoiding severe hypertension, but whether one agent is better or worse than the other for preventing severe hypertension is currently not known. The conclusion of the Cochrane review in 2018 was that high quality, large size randomised control trials are required to provide reliable estimates of the true benefits and adverse effects of antihypertensive treatment for mild to moderate hypertension in pregnancy. And that's what the Giant PANDA trial will be delivering. We did a feasibility study in 2017, which was run by Louise Webster, and we recruited women for the feasibility RCT from St Thomas's in London, from our centre in Manchester, from Leicester and from St George's Hospital. And in that feasibility study, we recruited 114 women with chronic hypertension, so slightly different group, only women with a diagnosis of hypertension in the first half of pregnancy. And in that study, one of our main outcomes was to look at recruitment rate, and we recruited on average 2.6 women per centre per month. What's really important and really encouraging from the PANDA feasibility study was that 2/3 of women who were eligible and approached to take part in the study were willing to be randomised, and that included many women who were already taking either labetalol or nifedipine, but were happy to be randomised potentially to a different drug as part of the study. Although the sample size for the PANDA feasibility study wasn't powered to look at clinical effectiveness, we did see some differences in blood pressure outcomes. There was a difference in central aortic pressure, which is a method of measuring central blood pressure, which was lower in women randomised to nifedipine. There were some non-statistically significant differences in both maximum and mean systolic peripheral blood pressures, and similar rates of adverse outcomes between those women allocated to labetalol versus nifedipine. And we learnt an enormous amount about how to conduct a trial in this group of women, comparing nifedipine to labetalol by running the PANDA feasibility trial. And obviously all of the things that we learnt running that trial have been used to design the protocol of the Giant PANDA study. So the research question for the Giant PANDA summary study is in women with pregnancy hypertension, and that's women with both chronic gestational hypertension and preeclampsia. That's our population. What is the effective treatment with nifedipine compared to treatment with labetalol on severe maternal hypertension? That's our first outcome, our primary outcome, and alongside a composite of fetal neonatal death or neonatal unit admission. Our primary objective is to evaluate whether treatment with nifedipine compared to labetalol in women with pregnancy hypertension reduces the risk of severe maternal hypertension without increasing the risk of neonatal death or neonatal unit admission. And these outcomes, when we spoke to women affected by hypertension in pregnancy, these were the outcomes that women told us were important. Women recognise that if they have episodes of severe hypertension, it means they're more likely to be kept in hospital, they're more likely to have prolonged inpatient admissions, and they're also, very importantly, more likely to have iatrogenic preterm births. And that's clearly a very important outcome for women and for us as clinicians. We also need to know that any intervention in pregnancy is not increasing harm and so therefore we will, co-primary outcome is looking at the risk of fetal or neonatal death or neonatal unit admission. Secondary objectives will be to look at the impact of nifedipine versus labetalol treatment on a host of other secondary maternal outcomes, including some additional patient-reported outcomes. And we'll also look at the impact on the NHS by looking at a cost-effectiveness analysis. Using the lessons that we learned from the PANDA feasibility study, we've designed a pragmatic and open label multi-centre 2-arm RCT. And I hope once you get familiar with the trial processes and procedures, you'll agree that this is a very pragmatic trial. It's open label, and therefore really the only thing that is controlled by the trial is the allocation of treatment, be that to labetalol or nifedipine, and all other aspects of the ongoing maternity care for that woman would follow normal clinical care protocols, with the drugs being dispensed from the usual care pharmacies, using the usual preparations available in your hospital. The trial will be set within 50 consultant-led maternity units across the UK, and we're looking for a sample size of 2,300 women. We'll be including women who are between 11 and 34 plus 6 weeks gestation with any type of pregnancy hypertension, be that chronic, gestational or preeclampsia. There needs to be a clinical decision made to initiate or continue the use of an antihypertensive drug, and women need to be over 18 and able to provide informed consent. There are very few exclusion criteria to the study, but the ones that are important are that are listed here, and they include those women who are unable to take labetalol because they have perhaps labetalol or nifedipine, perhaps they have asthma, for example, and they wouldn't therefore be able to be randomised to labetalol as their allocated treatment, and therefore they wouldn't be eligible to take part in the trial. And those women who are already requiring a high dose of both labetalol and nifedipine, where the clinician doesn't feel it would be possible to achieve the same antihypertensive benefit from a single agent. Now, it may be women who are only taking a small dose of labetalol and nifedipine, and that actually they could go on a single agent at a higher dose, and those women would be eligible to be included in the study. The intervention, as I said before, is any preparation of modified release nifedipine versus any preparation of labetalol dispensed by your usual care pharmacy. The primary maternal outcome is number of days with healthcare professional measured readings above 160 millimetres of mercury, so severe maternal systolic hypertension. And the primary fetal neonatal outcome is a composite of loss before birth or no neonatal death or neonatal unit admission occurring up to 28 days after birth, with a number, as I said before, of secondary and maternal fetal neonatal outcomes, including important patient-reported outcomes and the health utility resource analysis. So these are a list of the approvals for the study, which is now up and running in several centres, and we really look forward to having you on board and recruiting to the Giant PANDA study. Thanks.